Welcome, everyone. It's an honor to be here. And today the topic is going to be a little bit different from usual medical knowledge related topics which you want to cover during your sleep training. But this was sort of like based on feedback of several people who thought that in the current landscape of sleep medicine and general in medicine, one thing which we really need to learn about is also how do we manage crisis situation. It was, of course, the preceding years, it was pandemic, how it affected the workflow. And then obviously, another new relevant timely topic, the recall of the CPAP devices. So in current days, it's not just medical care only, but also the administrative aspect of how that medical care is delivered and dispersed, which is very relevant. Just by way of introduction, I'm Irfan, Sleep Fellowship Program Director of Hennepin Healthcare, and my clinical practice is at VA right now with University of Minnesota. I have no financial disclosures to state. The goal of today's topic is going to be to provide brief regarding the PAP device recall crisis management. And the main objectives are going to be, number one, to describe the impact on OSA care, explain the risks from the reason of recall, relate the strategies to direct care of the affected patients, and strategize care of newly diagnosed patients. So I also want to leave a good chunk of time for Q&A in the end. So definitely, please feel free to put your questions in the chat box, or even at the end, we can open the floor. But what exactly is crisis management? It's more of a business term, which we are not used to using in the medicine world. But basically, it refers to the identification of a threat to the workflow of an organization and its stakeholders in order to mount an effective response to it. So the main key features, and of course, if you go through business curriculum, there's going to be multiple layers to it. But the main process key elements are identification of the crisis, analyze and act accordingly, review and control, and then monitor the crisis. So these four categories. So since we will be obviously touching now in detail upon the topic, but I wanted to kind of, put this framework in the beginning as to how we can take a step back from an acute issue which arises, and then keep in mind that we have to cater to all core features. Now, coming to the gist of the point. In the second week of June of this year, on 14th of June, Respironics, which is one of the major manufacturer and provider of CPAP devices, issued a voluntary recall for some CPAP and BiPAP and other ventilatory devices. The recall was associated with the potential health risks related to the polyurethane sound abatement foam, which is used in several of these devices. The potential health risks include exposure to the degraded foam particulate matter and chemical emissions, as well as volatile organic compounds. And what they also stated was that the degradation and these emissions can be aggravated by use of unapproved cleaning methods, such as ozone and ultraviolet cleaners, and very high external heat and humidity environment. So in the end of June, FDA also issued the statement corroborating that. And then, we will talk a little bit about how it impacted our sleep practice. But before, I wanted to go over some of the common potential risks of the exposure to this foam. So some of the potential risks can include irritation of skin, eye, and respiratory tract. It can lead to inflammatory response, headache, worsening of asthma symptoms or asthma-like symptoms, adverse effect to some of the other organs if ingested, such as kidney and liver, and even potential toxic carcinogenic effect. So these are potential risks. What actually has been reported so far in 0.03% of the patients, they reported headache, upper airway irritation, cough, chest pressure, and sinus infection. And when they, obviously, after these complaints were brought to light, it started happening in even before this recall, obviously, a few months before. And initially, this was attributed to perhaps, cleaning, unapproved cleaning methods and probably inappropriate cleaning. But then later on, it was discovered that it was more than that. And the long-term effects of this exposure to the foam are still unknown. But then when they checked the potential of toxic carcinogenic effect comes from some of these volatile organic compounds, and I will go into the actual compound chemical names as well, they failed the mouse carcinogenesis model. So potential exposure, risk of exposure to the emissions, they include these compounds, which I've listed: toluene, diamine, toluene, diisocyanate, diethylene glycol, dimethyldiazine, phenol, and they can lead to headache, dizziness, irritation if ingested and inhaled of the eye, nasal tract, upper respiratory tract, and skin. Hypersensitivity, nausea, vomiting, toxic and carcinogenic effects potential, but no reports of serious harm have been done yet. Now, which ones are the affected devices? It becomes to a certain point an alphabet soup, but if you go on this website, and I have included all these resources in this presentation as well, but just by view of listing, basically all the CPAP and bi-level devices manufactured before 4/26/2021. Now, having said that, it's easier to think if your patients have received these devices after that, to consider, to maybe thinking, hopefully wishful thinking is that maybe they would have received the newer devices. But keep in mind that the devices manufactured before this date would have been shipped, would have been delivered way before April. So if you see a patient in your clinic who may have received a device, probably in May, it is very likely that the device is going to be the affected device, or even before the recall in June, it is very likely because that was shipped and delivered and stored at the facility long before that. So some of these devices, like I said, I've listed these here: Trilogy 100, Trilogy 200, Carbon Plus, A-series BiPAP hybrid, A-series bi-level. But like I said, these devices, the list becomes even longer. Essentially, like I said, all CPAP and bi-level devices are included in the list. But then we have broken it down in terms of continuous ventilator, non-life supporting continuous ventilator, and non-continuous. So now, as a result of this, what were the patients or the physician committee told? When they put out the voluntary recall, the suggestion was what to do right at that point: continue life-sustaining ventilatory devices prescribed to the patients, but stop use of bi-level devices and CPAP apnea devices and consult your physician. Now, what I want to highlight here is that, in both these cases, whether it's a green, continue using the device, red, stop using the device, the main common feature is consult with your physician as soon as possible to determine appropriate next steps. And again, when telling them to stop using the device, consult your physician to determine the benefits of therapy and potential risks. Now, I think, this is the point which I want to highlight because it makes us really uncomfortable in clinicians' shoes as to we have a device which is on recall, and the organization's structure will vary too. Some of the sleep departments will have their own DME. Some of the sleep departments will not have their own DME, and the DME is a separate entity which is providing these devices to the patients. But the patients is not going to read the logistical workflow, obviously, right? They will, any question related to CPAP, their physician or their provider is their point of contact, and they were going to approach them. And they will pose all these questions, even based on the limited information you may have. These questions will be coming along your way. So this recall impacted within US 500,000 veterans. 500,000 veterans were on this recalled Respironics device. And beyond that, if we look at general US patient population, it was above 6.5 million. And outside of USA, it was actually greater than 15 million people who were affected by this device recall. Now, another thing which I wanted to kind of point out here is that Respironics has had a major market share of PAP distribution, of CPAP distribution. Of course, there are other alternative manufacturing companies whose devices are being used with good success, ResMed, Fisher-Paykel, Devil Bliss, but Respironics had a major market share within US and even outside of US too. So now that leaves millions of people, either they are not aware of this recall or they're wondering what to do. So for the patients, What to do in terms of the device replacement? One standard thing, regardless of whichever organization you're with, you can let them know to register the device through this website or through this phone number. So for anybody who has a recall device, needs to register to get the device replacement. Now, if the patients are reporting symptoms or complaints from the previous device use, then they can go to FDA Med Watch voluntary report and sort of obviously submit the complaint. This can be done by patient. There's a patient section. There's also a provider section. So either you, if somebody is reporting a specific complaint from the device itself regarding this recall, the particulate matter and the emissions, you can do it or encourage the patient to do it. So this piece has to be done. But for the clinicians, when you heard about this recall, then, what were the issues going in your mind? You have pre-existing patients, maybe you have new patients who are coming along your sleep clinics, and then potentially, other referrals which will be coming along your way in the face of shortage of supply. The first step is obviously trying to find what is the acute, as we talked about, analyze and control. The second piece, first is the identification of what needs to be done. Identification of the pre-existing patients, you can engage your health information management system there, and prosthetics department in some places, perhaps, DME identification, their HR, health record system, electronic record system to identify those patients who are on these devices. And then the next step is analyze and control. So after you've identified those patients, and there are a number of ways to do that, your hospital electronic health record team can try to base it out of the all sleep apnea clinic consoles, or it could be done based on the ICD-9 or 10 codes of sleep apnea. And then in conjunction with prosthetics or DME, they can actually look at the serial numbers and through cloud, pull the people, but there will be patients who are not monitored through cloud system too. So there they will have to look at the record. The second step after the identification comes communication to the patients. Some would hear it from TV or other sources, but then obviously, it's our clinical responsibility to let the patients know, even if the DME is not directly part of our sleep practice. Letter, email, or secure message, whatever is the system which is most nimble and efficient within your practice, and can get the message out to a broader population. Of course, that could be employed. It may also, I want to highlight here is that this would require additional resources. With the existing resources, which may be, already part of your sleep team, this is on the scale which is beyond the usual management. So engaging your organization's risk management team, safety management team, and public affairs office, I think, and your executive leadership. It's key to engage those people in this too, because obviously this will require engagement of your other disciplines as well. For example, primary care team, because the questions would be directed to them as well, mental health team, because questions may be directed to them for the complications too. Developing a phone tree, if possible, getting a dedicated line, and even if it's not a dedicated line, developing a phone tree to give instructions to the patients, because trust me, the phone line will get inundated. The first day when this recall was announced, before we even reached out to our patients, we received 114 calls. Our phone lines were ringing constantly. And after we started sending out message, then the number of calls increased to like 300 per day. So that affects the regular sleep clinic functioning too. So if possible, developing a phone tree with simple message in terms of, maybe these are the steps you could do, or maybe look out in your mailbox, or, continue using, if you have symptoms, continue using the device. So in discussion with your risk management team and your clinician team, depending on your patient demographic, and I will give you examples going forward as to what are some of the templates and messages, some of them which have been posted on AASM website as well, but some of them were used, those could be tweaked according to your patient demographics. Templates, having a specific template, because when you get inundated with 100+ calls in your clinics, then all hands need to be on the deck. So developing a specific template in terms of simplifying what would be the clinical strategy. And the clinical strategy would be determined by your clinical team and your medical director of the lab in conjunction with, like I said, leadership, and together coming up with, what is going to be your triage process according to your clinic. Developing some templates so it's easier for people to start using that template for documentation purposes. Because obviously we know it's a recall situation, obviously the question about, what may happen long-term in terms of even, legal pursuits may come arise. So it's important to document the discussions. And then the clinical decision-making, like I said, when you get so many patients and in terms of, who are the patients who should definitely stop it and who are the patients where the stopping of the device may put them at higher risk, rather than the risk from the foam itself. So that is the clinical decision making, which is on the shoulders of the clinician with less information, but then obviously that is ultimately that we have to kind of do in the best interest of the patient. Counseling of the patient and proper documentation, that is the key, because this becomes a discussion of risk and benefit again, which we have done before in medicine in various cases, even starting a person on a medication. Obviously, we always talk about the side effects. The difference is that those medications and those treatment strategies have a lot of evidence behind them. So we are more confident in discussing about, the benefits versus risks and alternatives. And in this situation, this hit us suddenly in mid of June with, gradually there are various pieces of the information which are evolving with time. Now, and then ultimately patient instructions. What are the patients supposed to do? Because you may give them the whole picture, simplified picture, what you have an idea about, but then they would be looking up to you. Some people may have strong opinions than others, but they would be looking for directions from the sleep doc. Now, this is an example of the letter, the communication, which has been put forth in the AASM guidance in terms of what you could use as initial message or initial communication to the patients. So this notice is putting your name, sleep center's name here, and then giving them some information about the recall and what are the next steps. And as I said, the next steps start with definitely register the device, regardless of whether they're using or not using. And then giving the contact info and more than one email, secure message if possible, phone number to the patients. Now, having said that, this sort of gives a good information, gist of information, but also depending on your patient demographics, we simplified our dissemination to the patient was much simpler form than this, and that was approved by our national office, national VA office, safety committees, and risk management committees. So like I said, individually, even though ASM has put forth some resources for you, take it up to your leadership and your department and sort of, come at a consensus as to what is at the readability gauge of your patient demographics and would work better. So this is an example of, like I said, of a communication. And then this is an example of note template. In case of, if you're telling the patients to continue the device, then what are the things that you should definitely document? Informing the patient of the risk, of the recall risk. And then if the patient is on ventilatory support, then the risk of discontinuation of the device is higher than the risk of adverse effects from the potential foam degradation. So those patients should continue using the device. Now, the other thing is also, and we will go through the medical decision-making tree as well, that if they have sleep apnea with symptoms, again, then the risk of discontinuation of the device may be higher than the risk of the potential of the particulate ingestion or inhalation. If they're using the device, then definitely they should avoid using all the ultraviolet or ozone device cleaners, such as SoClean, and high environmental heat and humidity. Now, having said that, this does not refer to the humidity of the device itself. This refers to external heat and humidity, such as, temperatures of 95 plus. And then endorsing what is the reason that you feel that this patient should continue using the device. Patient endorses significant symptoms of excessive sleepiness or drowsiness, without the PAP device, or, aggravation of underlying mental health problem without the device, or having significant impact on the quality of life without the device. And after the discussion of risk and benefit, mutual decision to continue the PAP device was made. And then extremely important, instructing the patient to register with the manufacturer, either through this phone line or obviously the website. And then similarly, this is a template in case of where the device should be held. So essentially, these are going to be the patients who have, very mild symptoms, which are not affecting the quality of life as much, and, milder degree of sleep apnea. But still, even with patients with mild degree of sleep apnea, they can still have significant symptoms. So that's why clinical decision-making is highly dependent on the symptomatology. Now, ASM I've included this link here, the clinical decision-making tree, as to guidance for us to sort of help direct the patients. And this has been various different sleep centers have developed their own clinical decision-making tree. VA has its own, other academic organizations have their own, depending on their demographic and, they're mutually agreed upon, decided upon decision-making. But it's helpful to discuss it as a group, as a clinicians group. So, then it becomes sort of like your workflow guideline or framework for you to follow. So going into the detail of the decision tree, this is a very busy slide, but I wanted to go through it just so, it'll walk through these main steps. And then the question and any questions we'll take at the end. This is, like I said, this has been put forth as a resource for you guys. Does your patient use any one of these machines? And these machines are basically advanced PAP modalities, Trilogy 100, 200, AVAPS, average volume assured pressure support, ASV, or bilevel ST. So these are advanced modalities with supplemental oxygen with their PAP device. So this group is kind of referring to any patient who potentially has advanced pulmonary compromise and is needing either some form of ventilatory support in form of pressure support being delivered. And then supplemental oxygen with their PAP device refers to also some cardiopulmonary compromise, which is affecting the gas exchange. And thus this patient is more complex than just regular sleep apnea only. So if the patient are using these advanced devices, the first question is, are they using one of these machines? If yes, then advise the patient to continue using device until it is replaced or repaired. So, and or patient can make an appointment to discuss treatment options too. But like I said, you won't be able to accommodate 100 calls or more than 100 calls to be sort of put in your clinic right away. So it's helpful to develop an easier checklist that you could sort of, train your staff to sort of go through this. If they do not have any of these devices, then looking at their comorbidities, does the patient have any of these diagnoses? COPD, hyperventilation, pulmonary hypertension, neuromuscular disease-related respiratory problems such as ALS, Duchenne's dystrophy, diaphragmatic failure, past or present cardiac arrhythmia, or heart failure. If the patient has any of one of these comorbidities, these can be looked at, problem list in your chart, in the electronic chart, if it's a number of calls that you're going through. And then if they have them, then the risk of their symptomatology and their aggravation of the comorbidities in the shape of discontinuation of the device is going to be much higher. So these patients, again, should continue using the device pending replacement. If the patients do not have these comorbidities, and, like I said, this comorbidity is sort of like a helpful suggestion to you, but then, depending on your program, you may, obviously add a few other things, such as some of these factors, which are more along the line of symptoms. If you go down, do any of these apply? So I want to highlight here, discontinuation of PAP therapy would lead to substantial deterioration of functional status or quality of life. So this can encompass a number of things. a number of things, meaning that if their sleep is extremely fragmented, that it affects their concentration and affects their functioning capacity during the daytime, then those people can qualify. Or if they're very sleepy without using the device, regardless of the degree of sleep apnea, then the improvement with the PAP use in their alertness level will obviously, mitigate the risk of them being of hazard while driving. So that would be included. Recent hospitalization for breathing problems, extreme sleepiness or drowsy driving prior to using CPAP or bi-level treatment. Having said that, obviously, by extension, people with narcolepsy or central hypersomnolence, if they have sleep apnea, then obviously, those could be in the same category. Occupational with operational safety requirements, for example, commercial drivers, for example, pilots, and obviously DOT license requiring treatment of sleep apnea. So if any one of these apply, then again, if this is yes, then again, the patient should continue using the device pending replacement. But if the patients do not have symptoms which affect the functional status or quality of life and do not have one of these other things, then they can hold the device use. If possible, get another device which is not impacted by the recall. Having said that, we are already facing shortage of that. Sorry. Okay. And then consider alternative options, such as oral appliance, such as positional devices for people who may have positional apnea. And then obviously look at the other factors that can aggravate their sleep-related disordered breathing, such as alcohol intake and weight loss. Knowing that all these things, obviously, especially weight loss, and these strategies are not going to be completely effective, but then at least some of the suggestions that you can give to the patients to mitigate. So all the resources, I've included the link here, AASM guidance and response. This includes the clinical decision tree. This includes information for the clinicians, instructions, the letter for the patient as well, and any updates which are coming along the way, and also details about various questions which came along the way. Now, I've kind of summarized here for clinicians. We talked about so far what to do with existing patients, but then you have this existing army of sleep apnea patients, but you also have incoming new consults, and for sleep apnea and for other things too. So that really sort of created a bottleneck in many of the practices. And like I said, perhaps in the last, I would dedicate the time to talk more about those issues, individual practices may have come across. But we also are dealing with, such as our community colleagues, other academic colleagues, dealing with shortage of supply for the new patients who may be just diagnosed. Some places have decided to hold the sleep testing, but that may make it more difficult, number one, to hold the sleep testing. You are not diagnosing the patients. And if the patients had other issues other than sleep apnea, which are more prominent, then you're kind of, not able to treat those. And number two, the backlog will be hard to sort of cater to without additional help when the sleep studies would start again. Some of the sleep labs were forced to stop. Those who were using the titration devices, affected titration devices in the lab. So for those labs also, the decision has to be kind of made internally within the group as to whether they want to completely hold the sleep studies, or some places have also created a waiver, a consent that, patient is willing, if their symptoms are significant enough, the patient is willing to use the affected device for the night of the titration only. So those consent forms are also available, as resources on the AASM guidance. But like I said, this decision first has to be approved by your sleep leadership within the group to decide. Because of the holding of the titration, diagnostic studies obviously have increased, or even home sleep apnea testing has increased posed by this. So then even developing, and I will go through that, how you can try to develop a treatment plan around your home sleep apnea testing and without being able to do the titration portion. So for clinician, for the new patients, triaging based on medical acuity, we never want to pick our favorite child. So it's important to step back and then sort of, come together as a clinicians group and decide about, depending on your supply, if you have 100 devices left and your monthly incoming sleep apnea consults are 200s, then how will you decide? And having a constant connection with your DME provider, or if the DME facility is within your practice, then having a weekly count of what the supply looks like. So triaging based on medical acuity, the patients with highest symptoms would be the first in line to receive the devices. The patient with intermediate with high would be second. The patient with intermediate would be below that, and then alternative options for patient who may be in the lower tier. So I will go through some of the proposed tiers as well. Counseling and consider alternative options. We already know that oral appliance obviously has been used before as well. Positional belts, those resources are out there, but this may be the time when we have to kind of leverage a little bit more on the alternative strategies, but then having a follow-up plan for those patients, because many of them may not be able to notice improvement with that. So having a follow-up plan in clinics is helpful, and creating registry for the patients if there's a shortage of supply, and if all the patients are not able to get the devices, then creating a registry. Now, the tiers or medical acuity, this is one example. This is not absolute by any means. So take it, discuss it within your group. What have they come up with? The highest medical, I included here, tier 1, tier 2, and tier 3. And the highest and high medical acuity are kind of included in tier 1. So to put it simply, anybody who has sleep-related hypoventilation would be highest medical acuity and should be on the top of the list to get the devices. And then when we look at other important conditions, comorbidities, chronic respiratory failure, which is exactly what I said before, neuromuscular disorders, COPD-related hyperventilation, or any sleep-related hyperventilation, cardiac causes, heart attack, cardiac arrest, congestive heart failure, pulmonary hypertension, acute stroke or TIA, occupational risk, as we hinted at before, pilots, commercial drivers, and mental health symptoms. This is a tough one. Mental health patients who have received benefit from the device use. And, of course, individually, we can give example. I remember a patient who actually ended up at the time of the recall, he received a letter and he stopped using the device. And then his insomnia, because of sleep fragmentation, insomnia became so worse that he ended up coming to ER, and he was having panic attacks at that time too. So, obviously we have to keep in mind that, like I said, going back to the clinical decision tree, affecting the functional status of the quality of life, that's a big one, which is harder to gauge in many cases. Hypersomnia. So patients who have significant hypersomnia, including obviously narcolepsy, idiopathic hypersomnia patients, and patients who may have hypersomnia related to fragmented sleep from sleep apnea, they would be obviously in this tier as well. And like I said, this last one, severe symptoms affecting quality of life, that encompasses a lot of things, and clinical discretion also obviously has to be practiced there. For these high acuity patients, order the PAP devices. For the intermediate tier or tier 2 would be patients who are not fulfilling the criteria in terms of comorbidity and symptoms in tier 1. They would be second in line to receive. You can provide them with the other strategies, some patient information sheet stating other strategies, which we talked about, in terms of raising the head of the bed, weight loss, exercise, avoiding alcohol, and oral appliance and positional devices too. Also, I want to sort of mention here that our dental colleagues have also been inundated, because obviously there's been a lot of uptake in dental referrals. So even in very mild cases, though historically that's usually not done in sleep practice, but in people who have more disruptive snoring, the boil and bite over-the-counter devices in this short period of time can also be suggested if your dental practices are not able to cater to large number or the volume of the patients coming. And the lowest inaccuracy acuity or tier 3 patients would be the ones who are non-compliant and who are not engaged in the treatment as much. So this technically is going to be, obviously not the clinical decision you're making. This would be kind of evident based on, what the patient may be doing. But the high medical acuity and the intermediate one, I would say that, these are the areas where you will have to kind of, think about triaging. And creating a registry for these patients, like I said, intermediate one, because if the oral appliance is not working for them or positional device is not working for them, then they still need some therapy, even if their symptoms are not severe enough, but they still have symptoms. That was the reason that they ended up coming to your clinic. Now, this is just sort of like a helpful suggestion, in terms of, especially for those labs and practices who are not able to do titration studies at this time and who have to resort to more home sleep apnea testing program. So even before, you are doing that test, think about the clinical comorbidities. This is slightly different from what we used to do in the absence of recall, obviously, because at that time, we would pay attention to patients' clinical situation in terms of, obviously, anybody who had symptoms and the disorder would get the device. But now we are trying to keep in mind the triaging of the higher acuity patients. So even at the time of, let's assume in virtual world environment, if because of pandemic too many of us are doing electronic consults or phone consults, reviewing the comorbidities at the time of, e-consult. And then if this is a virtual consult, then getting some sleep questionnaire and getting the symptomatology from those sleep questionnaires, such as Epworth Sleepiness Score or other electronic sleep questionnaire that could be filled out by the patients as well, if this is a non-face-to-face patient, and then proceeding with the home sleep apnea testing. After the home sleep apnea testing results are available, then setting up a criteria as to people with perhaps moderate sleep apnea and Epworth, which is in pathological range. Those patients, in conjunction with the comorbidities, if they fulfill the tier 1 in terms of comorbidities and in terms of the symptoms, then they're the ones who will go into tier 1 and who will get the device. And those patients who do not fall in the tier 1 category and have very milder symptoms, they could be in your tier 2 and, maintain a registry or consider oral appliances. So now just want you to remind that this is for electronic consults. This is for the patients who you're not able to see in the clinic and do detailed evaluation, to try to sort of make sure that we are still addressing them and, appropriately, and being good steward of our resources at this time too. So with that, I wanted to introduce one quick case. A 62-year-old veteran moved to Minnesota who has been on bilevel device for sleep apnea. He reports sleep study was done in an outside lab and he does not have the results. He has a device, but he needs replacement of accessories and thus contacts sleep clinic for assistance. But he does not know what are the settings of the device. The spouse reports very loud snoring with multiple episodes of gasping, choking, with arousals and some pauses in breathing. Patient also shares that he does not feel rested in the morning when he's not able to use the CPAP device at night and can easily nod off to sleep during the daytime activities. Past medical history includes COPD, hypertension, diabetes, heavy smoker, quit recently. So what are the next steps? How will you address this patient? And here are the options. What is the next best step? Single choice. And the options are: wait until you get outside records, tell the patient to register the device for replacement, provide the accessories for the recalled device, and tell him to continue using pending placement. Advise the patient to stop using the device due to risk pending placement. So, many of these options are going to be, correct answer, but the question here is, what is the next best step? So I see that the answers, maybe we can give 5 more seconds. I think most of them have replied.
Okay.
And then lock. So the answers are a split between second, overwhelming majority between second and third choice, which is tell the patient to register the device for replacement. And then the third one is provide the accessories for the recall device and tell the patient to use it pending placement. Some of us chose wait until you get the outside records and advise the patient to stop using the device due to risk. So as I said, none of these answers are incorrect, but the next best step for this patient will be provide the accessories for the recall device and, advise him if he's agreeable to continue using the device. And why is that answer correct? Because this patient is excessively sleepy during the daytime and he has COPD. We don't have the outside results yet. We don't know the degree of sleep apnea, but there is a potential that he's going to be an overlap patient. He will have sleep apnea with potential of COPD-related hypoventilation, even though we don't know the degree of that. So we would still want to see the outside results, outside records. And we should definitely tell the patient to register the device for replacement. So those things should also be done. But because the patient is falling asleep in his daytime activities, that is alarming. And if he feels drowsy when he's driving, then obviously he would be at safety risk for himself. We don't know what the patient is doing if he's a heavy machine operator. So, that's why sometimes we have to make a little bit of, uncomfortable, decisions, but then still it should be a mutual discussion, telling the patient that this is the risk. And even though the recall device has these potential health risks, but the discontinuation of the device may make you vulnerable to higher risk. And that's why this is what we are recommending. But, ultimately, obviously, the patient has to buy in to this suggestion too. So, like I said, the other answers are correct too. If the patient did not have significant sleep symptoms, then it would have been okay to advise the patient to stop the device pending placement. Like I said, registration of the device should be done regardless, and that would be the next step for this patient for sure. And we should look at the outside results so we can look at the extent of his sleep-related disorder breathing, what exactly it entails. Okay. So, for some reason, I'm not able to move forward. My screen is stuck. Okay. Now, case 2. 75-year-old patient who was found to have lung nodules 3 years ago and has been tracked in the pulmonary clinic, has been using PAP device after a diagnosis of severe OSA. After receiving recall notification letter, he's calling sleep clinic asking about whether the recalled Respironics device has contributed to lung nodules and what he should do. Now, this is a tough one. That's why I have not given any choice here. And, obviously, I would be open to hearing about comments. If anybody would like to unmute and, sort of talk about, wants to chime in, talks about this particular situation. Anybody wants to take a stab at this? So this situation is obviously, more complex. What we know from this vignette at this time is that the patient had lung nodules, which were discovered 3 years ago. And then at some point after that, he was diagnosed with sleep apnea, for which he's been using the PAP device. Now, as I mentioned, that the volatile organic compounds emitted from the foam degradation have failed mouse carcinogenesis models. But so potentially it has carcinogenic effect, could have that. But this patient developed lung nodules before the diagnosis of sleep apnea. So probably in his case, the exposure to sleep apnea this device has not caused the lung nodules, because tumorigenesis is a long-term process. It doesn't develop over a short period of time. It takes a long time for that to develop. So this is what we could, kind of suggest to the patient. But then obviously, as I said, the information is still evolving. We can't say at this time for sure whether in cases who may have cancer and who were on these devices for a longer period of time, we can't say for sure about the causation at this point. So far, what the company is reporting is that they're continuing to gather the data, and so far nobody with life-threatening or catastrophic or harmful condition have been reported yet. Now, current situation, on 1st of September, Philips finally received authorization for the new foam. So far what they were doing was that the newer devices, DreamStation 2 devices, had a different foam, silicon-based foam, and they were trying to give those devices for replacement for those patients with high medical comorbidities. Until they would ramp up, and their plan has been to replace the devices which are already affected and then disseminate to the new patients. So obviously, so far as you could see, it's going to be a big feat to replace the devices. But then after this emergency approval of the new foam, now the process will occur in terms of in terms of repairing the old devices as well. So far, the process, this repair will begin in September. It has not begun yet. And the intention to complete the idea is that in the next 12 months, they're aiming to complete the repair and replacement. So as you can see, this shortage of CPAP supplies is going to be taking months, if not a year. So far, Philips has hired a third party to sort of deal with this recall-related issue. What is happening is that the patients, after registering for replacement, when they get to them in the queue, they receive a device, a DreamStation 2 device at this point before the approval of this one, with a sleeve of mailing them back the older device. And the DMEs, the Respironics, together with the DME, is responsible for making sure that the device they're receiving, the new device they're receiving, is set at their settings. So this is the process going on so far. But then obviously now that they have the new foam approved, now they will begin the repair process and then go from there. Now, there are, of course, there are other multiple nuances regarding the situation as well. And I wanted to open the floor for any discussion, any Q&A. But then the important thing is not to lose the calm. Coming back to that point, after analyzing and acting, review the process, monitor and review the process, because you may need to come back and change few things as to how you're dealing. One other important point is, with all the home mechanical ventilatory devices, a bacterial inline filter can help with a particulate matter, so that should be used with the mechanical home ventilators. It is not advised to use inline bacterial filter with the CPAP or regular bi-level devices. So that question has come up as well in various discussions. So in the chat box, somebody also asked a question regarding what is the process of repair through Respironics. They have not divulged the details of that yet. This was just announced that they will begin working in this month of September. What they had shared up till now is that the newer DreamStation 2 devices will go to the pool of the patients who need replacement first before they are given to the regular audience. Any questions from this is going to be an evolving process, of course, going forward as well. We are anticipating, especially this learners group is definitely going to be affected by this recall in general. And then obviously we are facing pandemic too. So, this sort of brings home to the point that how our workflow needs to, sometimes things happen where we need to reshape and sort of, be flexible and change our workflow and continue to monitor and assess that. I'm thinking of a few other questions which have come up. There have been patients who obviously are not willing to use the new Respironics device. Sometimes they express distrust. So Philips is also saying that they would be willing to refund for patients who do not want to use their devices, even if it's replaced by the approved one. So of course, that process, how it will work out is not clear yet. Initially in the process, the message through this third company was slightly different. So it's important to the patients who are even registering to get an idea of whether they're getting appropriate information or not. A couple of other things, like I said, it's important to also include, your general primary care team and, other ancillary staff to engage them in this basic conversation in terms of, giving them some simple communication to pass on to the patient until the sleep team is able to address all these questions in detail.
There is a question in the chat. Will the AASM set up a task force to develop a policy for manufacturers to announce future equipment-related recalls? This Respironics recall created a lot of panic in the patients without qualification of risk in terms of duration of exposure, etc. It also inundated staff at doctors' offices without having enough information from Respironics.
Yes, that's high time comment, well taken. I will communicate with the AASM team too, but how it will be handled, that remains to be obviously decided by the leadership committee. But I agree that this was sort of like in terms of impact, at least in my sleep practice, I feel like it has had bigger impact than even pandemic affecting the sleep medicine practice. And I echo, staff has been inundated with very little information, multiple meetings, and obviously every practice has had meetings with them separately and together with the professional societies. So the other thing which I also wanted to say here was that this was one time when ASM, there are in that link which I put forth, also the other slide presentations have been posted, which were done in conjunction by representative from American Academy of Sleep Medicine, American Academy of Neurology, American Thoracic Society, and CHEST. So, all the stakeholders came together on this platform to sort of try to help, create some method out of madness. But yes, ultimately, this is a policy and logistical issue, administrative issue. But the clinician side was kind of thrown in the mix of things with little prep. That's part of the reason, even though our webinars are mostly directed at, sleep-related didactic topics to cover, that it was felt by the committee that this is important to give a flavor of what was happening in the background, because most of our learners, obviously, you guys started in July. So, at the pace as to how this evolved, you were amidst of it, but then you may have not seen the initial part of it. Anybody would like to pose any question from the patient that they may have heard or were not able to answer for the patient and would like some input from rest of the group? Well, I can perhaps share some of the anecdotes. When we were giving bacterial filters, inline filters to the mechanical home ventilators, there were some patients who were specifically asking me if they can do anything to try to mitigate this particulate matter. So of course, other than not using the ozone cleaners or ultraviolet cleaners, avoiding external heat and humidity, they were specifically asking for filters too. The thing about filter is, even if we use bacterial inline filter, the guidance by Respironics is at this time that we don't know how putting in an inline filter will affect the pressure delivery and affect the algorithm of the CPAP and bilevel devices. The inline bacterial filter have been used during pandemic for home ventilators. So we have some idea there, but for CPAP and bilevel devices, those have not been used. So how they would affect the delivery, that is not known. The other thing is that the high efficiency filter can filter out perhaps the particulate matter, but not the gases, not the volatile organic compounds. So the visible particulate matter can be, yes, filtered out up to 0.3 microns, but the gases will still be there. But there were patients who knowingly wanted to use the inline bacterial filter, and some did. The caveat, though, is that with inline bacterial filter, the use of humidifier is not very compatible, as it can clog up. And that's what led to some of them just resorting back to using the humidifier without the filter. Some people even ask question if they can try to take the foam out themselves. Some patients felt that the filter was the sound abatement foam. So we clarified that the filter they use is not the sound abatement foam. And obviously it is discouraged to have them try to open the device to take out the filter, not the filter, the sound abatement foam on their own.